Hello, everyone. Thank you very much for joining us today for our webinar, Understanding Medicaid, What Advocates Need to Know. We are really honored to have two wonderful experts who are going to help us understand Medicaid, how it works, what are some of the proposed changes that are being discussed right now in Congress, and why Medicaid is so important for cancer patients and cancer survivors. This is a topic that we haven't talked about a lot, and so we thought that we would give people some education on why Medicaid is so important and what the proposed changes might mean for cancer patients. It's definitely an important part of our advocacy, but because it's a topic that we haven't spent as much time on, we wanted to do some background. There's a lot of complexities to Medicaid. It's a federal state partnership, and there are different pieces to Medicaid, including Medicaid that was around before the Affordable Care Act and the Medicaid expansion. And there's a lot of different things being proposed right now. So that's why we wanted to kind of have a foundation and then really delve into how important it is for cancer survivors. So I'm really honored to have Dr. Heather Saunders from KFF and Dr. Robin Yabroff from the American Cancer Society joining us today. Heather's going to start by talking about what Medicaid is, how it works, and what are some of the proposed changes. And then Robin is going to talk about what it means for cancer patients. And then at the end, we'll talk about what you can do and we'll answer questions. Before we start, I just want to remind you that we will share the recording and the slides after the presentation. They'll be available in the next couple of days. And we're also building a resource on our website for information about Medicaid. So now I'm going to turn over to you, Dr. Saunders.
Thanks so much, Shelley. Hi, everybody. Great to be here today. I'm excited to talk to you about Medicaid and give a little bit of background information, as well as potential funding cuts that are being discussed. Can everyone see my slides? Okay, great. So my name is Heather Saunders. I'm a senior research manager at KFF. I work mostly on Medicaid policy, substance use disorder policy, and mental health. KFF is a nonprofit, nonpartisan health policy organization. We have three parts. We have polling, policy, and news. I work on the policy side, and my objective is to provide unbiased data and policy analysis to inform current conversations such as these. So what I hope to communicate to you today are three main pieces. One, I hope that you leave with a general understanding and background of Medicaid, who it serves and how it's financed, as well as potential proposed cuts on the federal end and some implications for people. Okay, so to start with, I'll go into the Medicaid overview first. One of the basic foundations for the Medicaid is that it is an entitlement program and it is a federal and state partnership. So one of the core components is that states receive a federal matching funds to cover spending for Medicaid. And that'll come up again and again in today's presentation. Medicaid plays a central role in our healthcare system. It provides health insurance coverage to 1 in 5 Americans. It also covers 12 million people who also have Medicare, provides over 50% of the country's long-term services and supports financing, and also helps with other to address other key areas and challenges that come up, such as social determinants of health, maternal health, behavioral health. It is a safety net program and also helps financing for states and health systems. We know that Medicaid enrolled adults who are between the ages of 19 and 64 report substantial health needs, with 3 and 4 non-elderly adults reporting at least one chronic condition. A third of non-elderly adults have 3 or more chronic health conditions, and these can include behavioral health conditions, physical health conditions, or chronic cognitive impairment conditions. And this rate is higher than other non-elderly adults with private insurance or who are uninsured. People with Medicaid report that they have similar access to care as people with private insurance and far better access to care than people who are uninsured. So Medicaid finances or pays for nearly 1/5 of all healthcare spending in the US, 19%. Medicaid spending is disproportionately for people who qualify based on age 65 plus or people who have a disability. So if you look at the bar on the left, people who are the green bars, people who qualify based on age 65 plus or people under low income or people who qualify based on an eligibility account or disability account for 23% of enrollees, but their spending is over half of all Medicaid spending. So this is that part that I mentioned a moment ago. This is related to financing for Medicaid. As I said before, it's a federal and state partnership where the state government pays a share of Medicaid spending and the federal government pays a share. Across all eligibility groups and spending categories, that share is at least 50% of Medicaid spending that the federal government covers, but in some states it's more. And states that are lower income have higher amounts that the federal government contributes. So this isn't the same for all populations. Some populations have higher FMAPs or federal Medicaid assistance percentages that are covered by the federal government. For example, people who qualify for Medicaid based on Medicaid expansion, ACA expansion that happened in 2014, states that chose to adopt that, which is 41 states, including DC as of this month. The federal government pays 90% of spending for individuals who qualify under Medicaid expansion. Medicaid expansion covers low-income adults in states that expanded who have incomes in most states up to 138% of the federal poverty level, which is about $21,500 for a single adult. Something else important to know is that Medicaid is the largest single source of federal funds for states. About a third of state budgets go towards paying for Medicaid. And for federal expenditures that states get, 57% of the money that states get from the federal government is for Medicaid. So the takeaway message here is that Medicaid, federal Medicaid dollars, and Medicaid spending in itself is an important piece of state budgets. So now I want to go through some federal proposals that are circulating to reduce Medicaid spending, which has been a big conversation at the federal level. I won't have time to go through all of the proposals, but I'm going to go through a couple of them in hopes that that will give you a sense of some of the conversations that are happening right now. So Congress and the Trump administration are expected to debate significant changes to the Medicaid program. The House Budget Resolution includes up to $880 billion, which are in cuts, which are expected to mostly impact Medicaid. The Senate also put out their version of the budget, but their targets are less clear. So some of the ideas that are being floated related to Medicaid include imposing work requirements as a requirement for people to have Medicaid coverage. And another is per capita caps on expansion group. I'll explain what that is in a moment. And as you can see, there are more, but I'll just go into those two for today. Before I get into that, everybody has probably heard a lot of conversation around fraud, waste, and abuse, which are kind of terms that are being buzzwords that are being thrown around a lot. And these words are at the forefront of current debates and have been used as a basis for making changes in the Medicaid program more broadly. These are program integrity terms, but there's been a lot of confusion and a lot of misuse of some of these terms. So I'm going to take just a moment to define some of the main terms for you, because a lot of the numbers that have been floated about fraud, waste, and abuse are actually improper payments. So a few program integrity terms, along with a couple of very brief examples as to what these are. What is fraud? Fraud is intentional deception. It's a criminal act. So for example, a provider who bills for services knowing they aren't provided is committing fraud. Abuse is a bit of a lower level of that. It violates accepted standards. So maybe they're providing the services, but maybe the services aren't exactly necessary, or they're substandard services according to what's generally accepted. Waste is a misuse of resources. So an example of this is unintentionally duplicating lab tests, or maybe having multiple administrative paperwork requirements that that Medicaid or providers have to fill out multiple times. Improper payments is what's most often confused for fraud. Improper payments are incorrect or miscalculated payments. They account for about 5% of all Medicaid payments. An example of an improper payment would be a claim that's paid that's missing a service date. So when providers submit bills to get reimbursed with Medicaid, they have to fill out certain things. An example of that would be like a date of service that the service was provided on. And Medicaid programs are supposed to ensure that all of these fields are filled out before they pay that claim. Sometimes the Medicaid program or a managed care organization in Medicaid will pay for the service, even though one of those fields is missing. So research and monitoring that's looked into this finds that of the 5% of improper payments, about 80% of those are due to paperwork errors, essentially. Okay, now moving back just a moment to the House proposal, which was to cut $880 billion in Medicaid spending over the course of 10 years. This slide helps put that in context. 88 billion over 10 years is 88 billion a year. And based on average spending for different populations, this is the spending for the population equivalent to 88 billion in federal cuts. So 88 billion is 18% of seniors and people with disabilities in Medicaid. 38% of people who qualify through expansion or other adults who qualify for Medicaid, or equivalent to 76% or 3/4 of children, because children are one of the lower cost groups that Medicaid covers. Something else that's being floated are work requirements. Work requirements are being floated or discussed two ways. One way is through a federal work requirement, where the federal government might say something like, in order to receive Medicaid benefits, people have to show that they're working, or they have to meet an exemption. Maybe people who have a disability or who document certain types of health conditions would be considered exempt from these work requirements. Right now, data show that about 92% of Medicaid enrollees are working or have fallen to one of the following categories. They're attending school, not working due to an illness or a disability, or they're not working due to caregiving. So that leaves about 8% of people who are not working because they're retired or they can't find work. When other research has looked into this 8%, they find that people who aren't working that are Medicaid enrollees are more likely to have significant health issues or have substantial mental health needs. So work requirements, you may remember this discussion from several years ago during the first Trump administration. Some states did pass work requirements during the first Trump administration, and we learned some things from when work requirements were passed. Arkansas is the only state that passed work requirements and implemented them, so that's the state that's most often looked at as an example. They found that work requirements, I should back up and say, are not just that people are working, it's that they're working and reporting and documenting that work. Or if they meet an exception, are they documenting and communicating that exception in the way that the Medicaid program specifies? So it's not really just work requirements, it's work and reporting requirements. So when Arkansas implemented work requirements, 18,000 people lost coverage, 18,000 Medicaid enrollees lost coverage. And the people that lost coverage primarily lost it due to confusing paperwork requirements, not realizing that they met an exemption, for example, maybe a disability or another exemption. And then there were a number of people that did work, but didn't submit but the reporting requirements weren't met. So when the 18,000 people that lost coverage, when researchers looked at that population, they found that people who were disenrolled were less likely to adhere to medication, more likely to report delays to care, and also more likely to have medical debt. So those were some of the downstream effects of work requirements and the way that they were implemented in Arkansas. Research shows that access to affordable healthcare supports work and helps people maintain and find work, not the other way around. So another discussion that's happening is kind of a tongue twister called per capita caps. So going back to the basic financing mechanisms of Medicaid, is that federal state match. As I mentioned, for ACA expansion populations, the federal government pays 90% of expenditures for this population, and the states pay the other 10%. So what's being proposed here is that the federal government will place a per person spending cap on what they're willing to pay for spending for expansion populations. Right now, that's at 90%. We don't know what the exact numbers would look like, but we do know that if a per capita cap is implemented and that cap is static and doesn't adjust with inflation or medical inflation, that what essentially would be happening is that amount would decrease from year to year down to 69% in 2034, 10 years from now. So it would kind of be like a slow boil reduction of funds, of federal funds going towards covering this population. So if federal funds are paying less for this or other populations, that means that states have a bigger piece of the pie to pick up. So states have difficult choices to make. They can choose to reduce coverage for certain populations. They might choose to reduce benefits in some areas. They could choose to maybe reduce cuts or cut spending in other areas that aren't related to healthcare, like spending on education, or they could choose to raise taxes. So none of these are especially appealing options to states, and we don't know which direction they would choose to go. If, though, states decided that they couldn't make up the gap in the ACA expansion match due to fewer federal dollars, and they decided that all states that are expansion states decided that they are going to drop their ACA expansion populations, then enrollment would decrease by 20 million. And this varies from 19% to 49% of Medicaid enrollment across states. Implications for people. Medicaid is a popular program. When we do polling, majorities of people, regardless of their party affiliation, race and ethnicity, and income, view Medicaid favorably. People with Medicaid, we asked them about cuts to the program, and we asked from varied race and ethnicity, and we also varied party affiliation. For example, a 55-year-old white female said, for me, it would probably lead to death. And that's kind of harshly speaking, but it's the way that it would be. I've relied upon Medicaid for myself in order to survive. For my son, it would be survivable, but it would be difficult. He has real bad allergies, and he wouldn't be able to hear. When we look at Medicaid enrollment by congressional district, we see that Medicaid in both Republican and Democratic congressional districts have 21% or more residents enrolled in Medicaid on average. So Medicaid is a substantial, that covers about a fifth of people. Thank you. And these slides will be available, and please reach out if you have additional questions.
Thank you, Heather. And now we'll turn it over to Robin.
Hello, everyone. And I am going to, my name is Robin Yabroff, and I am the Scientific Vice President, and I lead the Health Services Research Team at the American Cancer Society. And I sit within the Discovery Pillar, which is a research group within the American Cancer Society. I am going to build on a lot of the information that Heather provided you. I'm going to talk specifically about Medicaid and access to cancer care and patient outcomes. I'm going to start with some background about cancer survivorship in the United States. And currently, there's about 2 million cancer diagnoses every year, and also currently about 18 million cancer survivors. And even though for some cancers, the incidence rates are declining, the population itself is both aging and growing. And because cancer risk increases with age, we expect about 26 million cancer survivors by 2040. So this is a large and growing population. And compared to people without a cancer history, cancer survivors can experience lasting effects of both disease and its treatment, including things like risk for new cancers and other chronic conditions, and also worse health-related quality of life. And both of these increased risks suggest that this is a population that really needs comprehensive and sustained health insurance coverage to make sure that they can get the care that they need. Importantly, cancer survivors also can experience limitations in the amount or kind of work that they're able to perform. And what this means is potentially reduction in household income if people are not able to work, but also reduction in access to employer-sponsored health insurance coverage. And that is critically important because that is the primary source of health insurance coverage for the working age population younger than 65 years. So not only may people and their families be facing a cancer diagnosis, have additional healthcare needs, they may also have limitations in their ability to maintain household income and access to comprehensive health insurance coverage. And unfortunately, in the US, we have stark inequities in cancer care and outcomes by factors like geography, race and ethnicity, socioeconomic status, and importantly, health insurance coverage. And I will also say many of these inequities are driven by the lack of health insurance coverage or a lack of comprehensive health insurance coverage. I'm going to share some data with you from a study we conducted. So we examined cancer mortality rates by congressional district, and in this map, I am showing you cancer mortality rates by congressional district. And in red, that is the highest mortality rate. And the areas in blue are the lowest mortality rate. And I'm using my mouse right now. Importantly, in these red areas, mostly the southeastern portion of the United States, cancer mortality rates are frequently double those in areas in blue. So we see these really strong geographic patterns in cancer mortality, and this is among males, and these data are a little bit older, but I'll come back to that in a little bit. So I mentioned that a lot of the inequities we see in survival and mortality are driven by health insurance coverage. And here I'm sharing some national data about newly diagnosed colorectal cancer patients. And we're looking at survival following diagnosis by both stage, which is one of the strongest predictors of survival, and also health insurance coverage. And the way to interpret this graph, we're looking at years of diagnosis on the x-axis and percentage alive on the y-axis. So you can see here the lowest line, which is stage 2 diagnoses who are uninsured, they have the worst survival. So it's not especially surprising to see that patients with stage 1 disease who are uninsured have better survival than those with stage 2 disease who are uninsured. And there's also a lot of evidence that people who don't have health insurance have worse survival compared to people who have private health insurance. The thing that's really surprising, though, is that for patients with stage 1 disease who are uninsured, they have worse survival, meaning that this line is lower than patients with stage 2 disease who have private health insurance coverage. Again, health insurance increasingly is a critical component of access to care following a cancer diagnosis. And so these data are just for colorectal cancer patients. We repeated this same study using longer term data and found the same patterns for when we looked at all stageable cancer sites combined and also 6 individual cancer sites, so colorectal, prostate, esophagus, liver, oral cavity, and non-Hodgkin lymphoma. And for all of these 6 cancer sites, as well as all cancer sites combined, health insurance coverage appears to be at least as strong of a predictor of survival as stage of diagnosis. And so these inequities in cancer survival mortality reflect lack of health insurance coverage and also breakdowns in access to care across what we call the cancer control continuum, which is what these little boxes here represent. So things like people are not receiving highly effective risk assessment and prevention. So, for example, someone without health insurance coverage may not have a usual source of care. They may not receive recommendations for smoking cessation. So they lack that risk assessment and behavioral counseling. If they do receive that, they may not receive recommendations for screening and an early evaluation and signs and symptoms of cancer. If they do receive screening, they may have delayed follow-up, potentially leading to delayed diagnosis in later stage. If they lack health insurance coverage and access to care, people are more likely to underutilize effective cancer treatments and also less likely to receive early palliative care, which is increasingly important in terms not only of addressing symptoms, but also we are starting to see that patients who receive both effective treatment and palliative care have better survival. They're also less likely to receive coordinated survivorship care. And then finally, lack of coordinated palliative care at the end of life. So we are seeing not just the research that we've conducted, but literally decades of research has shown that people without health insurance coverage are less likely to receive care across the cancer control continuum. And so based in part on the decades of research about health insurance coverage and its relationship to cancer care and outcomes, as well as many other health conditions. The Affordable Care Act was signed into law in 2010. Uh, Several of the provisions were enacted in September of 2010, including dependent coverage expansion and also elimination of cost sharing for preventive services. But really, the majority of the provisions were implemented in 2014. A number of things that are really important for people with cancer history or at higher risk of cancer. So, elimination of pre-existing condition exclusions and elimination of lifetime and annual coverage limits. Importantly, in 2010, nearly 50 million non-elderly adults did not have health insurance coverage. As I mentioned, in 2014, the majority of the provisions were implemented, but following the passage of the Affordable Care Act in 2010, it became highly politicized, and states could decide whether or not to expand Medicaid income eligibility to the populations that live there, to their residents, up to 138% of the federal poverty line. So this map shows you in blue the states that expanded Medicaid income eligibility either in 2014 or prior to 2014. And in orange are those states that did not expand Medicaid income eligibility. And I'll note that in the states that did not expand, eligibility is as low as 17% of the federal poverty line in some states, and single adults without dependent children are not eligible for Medicaid coverage in those non-expansion states. So now I'm going to share some data from a really great study led by my colleague, Dr. Shusong Han. And she looked at Medicaid expansion among people, the association of Medicaid expansion among people newly diagnosed with cancer, and looked in this first study looking at the percentage of people who were uninsured. And again, Medicaid expansion states in blue and non-expansion states in orange. And if you look at these neighboring states, so Tennessee and Kentucky, Kentucky expanded, Tennessee did not. You see that the percentage of uninsured patients newly diagnosed with cancer in 2010, 2011, 2013 was fairly similar, and then a dramatic drop in 2014 in Kentucky, not so much in Tennessee. You see a similar pattern in Arkansas and Mississippi. Arkansas expanded, Mississippi did not. In Colorado and Utah, you actually see higher percentage of people who diagnosed with cancer who were uninsured in 2010 compared to Utah, but that declines again in 2014. And then Oregon and Idaho, you see in 2010, Oregon also had higher percentage of newly diagnosed patients who were uninsured compared to Idaho, but by 2014 it dropped. A really important point I want to make is how quickly this happened in 2014, how quickly this drop in patients who are uninsured happened in those Medicaid expansion states. If we look at these same data in a slightly different way, so now stratified by rural and urban areas, you see on the panel A on your left, or my left, Medicaid expansion states, you see that the percentage of patients who are uninsured dropped dramatically in both rural and urban states, but that difference between the two virtually was eliminated, but not in non-expansion states. And you see that it remained high. One thing I do want to point out is the fact that some states decided to expand and others did not gives us what we call a natural experiment. So we can compare what happened before and after Medicaid expansion in both expansion states and non-expansion states. And that takes into account the fact that the percentage uninsured was actually higher in non-expansion states, both urban and rural non-expansion states, than rural and urban expansion states. Another study, also led by Dr. Shusong Han, shows that Medicaid expansion was associated with reductions in disparities among newly diagnosed patients by the area level poverty. So this purple line here represents the highest area level poverty. And you see here reduction in disparities in insurance coverage in 2014, and it happens pretty quickly. Importantly, all benefit, but the benefits are largest for the target population, that people living in lower income areas and expansion states, but not so much in non-expansion states. If we look at reductions, if we look at cancer survivors, and we look at uninsurance among cancer survivors, we see similar patterns. And I want to note that I added a line here in 2014 so you can see when the expansion happened. And you also see that the percent uninsured continues to decline after 2014. And that is something we see in a lot of our research, that the effects are stronger over time, potentially suggesting that once the expansion happens, it is patients are better able, providers are better able to make sure that patients can enroll and get access to care that they need. So again, disparities in coverage among cancer survivors reduced in expansion states, but not in non-expansion states. And in fact, you see a little uptick in 2017. And that was a year when there were other issues related to, or other threats to the Affordable Care Act, which reduced coverage in many non-expansion states. Similar pattern if we look at care unaffordability. And so what I mean when I say care unaffordability is that patients report, or cancer survivors report, they needed care, but they couldn't get it because of cost. In other words, they could not afford to receive the care that was recommended to them. We see declines in expansion states, and again, not in non-expansion states. And when we compare the two, there's statistically significant improvements in expansion states compared to non-expansion states. And so over the past 15 years, our group at the American Cancer Society and many others have been examining Medicaid expansion and what it means for healthcare, but also more specifically cancer care and outcomes. And we're looking in the target population of adults 18 or 19 to 64 years. And we see increases in recommended cancer screening. We see earlier stage cancer diagnosis, and this is really important because survival is better among patients diagnosed with earlier stage disease. We see increased receipt of timely and guideline concordant cancer care, improved care affordability. I just showed you some of those data, and improved survival following cancer diagnosis, as well as lower cancer mortality rates. We also see, importantly, reduced disparities in access, early stage diagnosis, and also survival. So reductions in long-standing disparities by characteristics like urban-rural status, race and ethnicity, and socioeconomic status. Importantly, we observed what we call spillover effects, meaning that there are benefits outside of the target population of adults younger than 65 years. In particular, we see increased coverage among children with cancer. And the thinking there is that there is a welcome mat effect, in that if parents are now eligible in enrolling in Medicaid, they're also enrolling, the children are enrolling as well. Similarly, we see increased coverage among older adults diagnosed with cancer who are age 65 and over. And the thinking here is the attention to Medicaid enrollment may mean that people who were always eligible are now enrolling and also benefiting from Medicaid expansion. There are also benefits for individual and community and state economic and budget. So like things like patients may not have to make as many trade-offs between food and housing if their healthcare is covered by Medicaid. And so we see reduced food insecurity in expansion states compared to non-expansion states. We see lower percentages of the population with medical debt, including medical debt and collection, fewer hospital closures. And right now we are in the process of looking at rural hospital closures, which is something is increasingly a big problem when it comes to access to care. However, as of April 2025, 10 states have yet to expand Medicaid eligibility. And as Heather mentioned and shared great detail, proposed federal cuts to Medicaid programs, which can also result in state cuts to those Medicaid programs. So I want to wrap up with a couple maps. This is the status of state Medicaid expansion decisions. Orange, those 10 states that have not yet adopted. And again, this map comes from the Kaiser Family Foundation, and it is a great source of information about Medicaid programs. But I want you to again look at these states that in orange that have, as of April 2025, have not expanded Medicaid in the southeastern portion of the United States. If we look at the percentage of newly diagnosed patients with cancer who do not have health insurance coverage, this map is very similar. The darkest blue represents the highest percentage, in some cases up to 12% of newly diagnosed patients without health insurance coverage. And I've shared with you how important health insurance coverage is for cancer patients and survivors. And then finally, we also see variation in foregoing care because of cost. Again, same pattern with the highest prevalence in dark red. These are the areas where cancer survivors are most likely to report that they need care, but they can't get it because of cost. And then back to one of the first maps I showed you showing cancer mortality. And I really want to emphasize the concern that without additional Medicaid expansion, the disparities between these states that did not expand Medicaid and those that did in terms of cancer mortality will only increase. Alternatively, many of the gains I've just described to you in terms of cancer screening, early stage diagnosis, receipt of guideline concordant treatment, early palliative care integration, and also survival and mortality, many of those gains will be lost if the cuts to Medicaid are achieved and also if there is not further expansion. So again, I want to come back to this cancer control continuum and talk about the critical importance of reducing inequities in access to care and protecting access to ensure everyone has a fair and equitable opportunity to prevent, detect, treat, and survive cancer. And with that, I am going to thank you very much. Looking forward to your questions, and I'm going to stop sharing.
Thank you very much, Robin. That was great. You always have such great data and you do a great job explaining it to help us understand. So I want to just kind of talk a little bit about the process right now. Their Congress is current. So one question was, can the president cut Medicaid by executive order? He cannot. That doesn't mean there's not things by executive order he could do to change the program, but the cuts that we're talking about now are things that Congress is considering, and they're going through a process called budget reconciliation. That budget reconciliation is a process that allows them to only have 50 votes in the Senate instead of having to have 60. And so they get sort of one shot at it. And they recently passed a budget resolution, which is sort of just like a roadmap for what they're going to do, but it's not binding yet. In that resolution, they instructed the Energy and Commerce Committee in the House, which covers Medicaid, that they needed to have $880 million in cuts. There's really nowhere else to make that level of cuts without touching Medicaid. So really the question right now is what changes will be made and how much it will cut Medicaid. They are marking up a bill May 7th in that committee. So that's when we'll see what the specific proposals are. So if you hear some in leadership saying things like, well, we haven't endorsed any cuts to Medicaid. They haven't yet, but they've said they have to cut $880 million and they can't do that without cutting Medicaid. So they're saying that, but it's not the whole picture. And so no specific cuts have been put on paper for the committee. There's a lot of things being discussed, but at that markup, May 7th, we'll know kind of what they're considering. We've been working really hard. Andrea has been meeting with a lot of members' offices on the Republican side, especially or mainly in partnership with the Partnership Protect Coverage, which has a lot of advocacy organizations in the cancer space and in other disease areas, including American Cancer Society Cancer Action Network. And we've been working together to encourage Congress both to extend the tax credits that would let people purchase plans on the Affordable Care Act and to protect Medicaid. So we've been having a lot of conversations, and there are a lot of kind of arguments that we are hearing that I'm going to ask you all a little bit about from some of the members who are skeptical. Now, another thing to note about the process is the Republicans are not unified. The Democrats are unified in support of Medicaid. So if you have a Democratic member, you can still call them. But what you can say is, what else can we do? Ask them how best to express your vote. But there's no Democrats who are interested in cutting Medicaid right now. The Republicans are mixed because some of them have a lot of constituents who are on Medicaid. And there are some that are the moderates that are saying, there's only so far I'm willing to go into cuts to Medicaid. And so some of the cuts that they're talking about are things like instituting work requirements. And one thing I would be interested in, Heather, if when you talked about the example in Arkansas and how many people lost coverage, how much did the state end up saving? Because I would imagine they spend a lot on all of the, monitoring the reporting requirements. The implementation of the requirements are expensive too. So do you know how much they actually save in the long run with these work requirements?
I don't have that number off the top of my head, but if you have another question, I can look up the answer very quickly.
Oh, okay. Yeah,
and
I
then
think we
get
do.
back to you.
Yeah, that would be great. So that's kind of the process. And so one of the things that we need to be doing is calling our members of Congress and telling them to protect Medicaid. We also need stories of people who used Medicaid for their cancer treatment. And Andrea put a link in the chat if you had access to Medicaid, or if you know of people who had access to Medicaid and it helped them with their cancer treatment, their survivorship care, any of that. What we need to do is bring the stories to marry with this data that we've been hearing. But I think calling your member of Congress is really important, particularly if you have Republican members, and call them every day. Call their DC office. You can call their district office. They don't really want to talk about Medicaid. We're finding that some of them won't take meetings if the meeting is intended to talk about Medicaid, but they really need to hear it from their constituents, it's not that they don't need to hear it from us, but they want to hear from their grassroots more than they want to hear from national organizations. So I would say to keep calling. If you don't know who your member is, you can go to congress.gov, put in your address, and you can find who your member of Congress is and your senators, and you can find their phone numbers, or you can call the congressional switchboard, which we can put in the chat, and you can just ask for your member and they'll connect you. And they're not always taking meetings, and they're not always having town halls. They're not really wanting to face people right now because a lot of the town halls haven't been going well and they've been advised, like, don't do it. So calling is probably the best bet right now. You can email too, but I think, they should still be answering their phones. Sometimes we hear that they're not answering their phones either because they really don't want to face the music on this. And but that is really the most important thing you can do right now, is to call your member of Congress. And if you do have members who are supportive, then ask them, what else can I do? And see what advice they give. But I think they really, when I think back to 2017 and we were fighting to save the Affordable Care Act, including Medicaid, but all of the pieces of the Affordable Care Act, we did not expect in January, when the House and Senate and President were all set on repealing, that we were going to be successful. And I think the reason it worked is because there was so much grassroots support for keeping these programs. So I think that's what it's going to take. I do think that we will be talking about this when we have our Hill Day in June, June 26th. For some of you, I know will be coming to that. We will probably have other things we're talking about as well, but given the timeframes, they had hoped to have this done by Memorial Day, but that's not going to happen. And I think by the end of June, we will be still talking about this, and we will be asking folks to talk about it in those Hill meetings. But just keep calling and call them every day. Don't call people who aren't your member. They don't want to hear from you. I mean, I know people want to just call the leadership, but they're not interested if you're not their constituent. So I don't think that's effective, but you can call every day. So didn't mean to take up so much time with that, but I know that that a lot of people want to know what they can do. So going to some of the questions. I don't know, Heather, you have your hand raised, so you found an answer. Thank you.
I didn't want to interrupt.
Okay.
Just real quick to follow up on your question. When Arkansas implemented work requirements, 18,000 people lost coverage. Many of those people were working, but just didn't meet the working requirements, or they were eligible for an exemption. I don't have the exact cost for Arkansas, but I do have a GAO report that shows that costs varied in the states that did implement. Estimates were from 10 million to over 270 million. For Medicaid specifically, work requirements did not significantly increase employment.
Great. Thank you. So, can you talk a little bit about, we hear a lot the argument that we're not going to cut services or coverage, we're just going to cut waste, fraud, and abuse. I know you talked a little bit about that, Heather, but can you say any more about that and what do they mean by, I mean, you talked about what fraud really is. Is there that level of fraud, or are they talking about other things that are not really fraud and abuse?
So fraud is often confused with incorrect payment. And those are the numbers that you hear thrown around quite a bit. There is no agreed upon measure of fraud. Detecting fraud is the responsibility of both the states and the federal government. And there are different people whose role is to monitor and try to find fraud. So we don't have an exact number or an exact methodology on detecting fraud. We know that, when it happens, it's often on the provider side. And it looks like one example of what it can look like is people billing for services, and services were, never given or received. So what we can measure is improper payments. And that's what I described during my presentation a little bit. What an improper payment is when a provider submits a claim for services rendered, they have to fill out the paperwork, and they have to fill out all lines of the paperwork in the way that the insurer, sometimes it's a managed care organization for Medicaid, sometimes it's a Medicaid fee for service, in the way that they specify. So if a piece of that information is missing and Medicaid pays the claim anyways, that's considered an improper payment. So 80% of the improper payments, and remember, improper payments account for about 5% of all paid claims. 80% of that 5% are due to documentation issues. And so those are the numbers, the spending related to those improper payments. And the improper payment isn't necessarily, remember, that the service wasn't rendered. It's that the documentation and the paperwork was not filled out correctly for the majority of those improper payments. So that's what we know about improper payments. Improper payments are not fraud. They're different things.
Thank you. So I saw somebody put in a link in the chat to send an email to Congress. That is great. I recommend you do it. I still think you should call, though, because that takes a little more effort on their part to answer a phone call, and they do track how many calls they're getting. So one of the questions was, what should we say in order to make a difference? I mean, I think that the main thing is the person who answers the phone doesn't necessarily want to get into a big conversation with you. I think the main point is you need to protect Medicaid. And you can say, I'm a cancer survivor and I know how important Medicaid is for people with cancer. Robin, you had all this data and all these charts. And what if you had to summarize into an elevator pitch, about the importance of Medicaid to cancer survivors in a sentence or two, what would you say?
Hmm. I would say, like, based on the strongest evidence we have,
Nice.
Medicaid is associated with earlier stage cancer diagnosis, better access to care, and better survival. So really, protecting Medicaid is critically important for cancer patients and survivors to make sure that they have access to care that's recommended for them and that they can afford it.
Thank
So
you.
I think, sorry, I
Uh,
went on, but this is
no,
an
but
area that I feel really strongly about.
right.
The
There's a
evidence
lot of
is
evidence.
so clear.
Yeah. And again, they're not if you call their office, you're going to get a receptionist who's not a health policy expert, and they're not necessarily, they may transfer you to the health policy person who might have more insight, but otherwise, I think you just say it's important that we protect it. There was a question that I thought was really good. It says the rhetoric is that there are countless persons in the program who are not eligible and just getting free health insurance. Can you address that?
I can talk a little bit about that. What I what I know about fraud and abuse and what Medicaid programs and others who do monitoring of this say is that the majority of the fraud is actually on the provider side and not on the enrollee side.
And that people who are receiving it are eligible by the laws. They're not getting it, they're not just getting free insurance, they actually meet the qualifications to get it.
In that when cases of fraud are looked at and when fraud is looked for, it's on the providers. So mostly providers who, for example, might not actually be providers, but they gain access to a provider MPI number and then maybe beneficiary numbers. And they pair the two of those together and they're not providing the services, but they're billing Medicaid for those services. So that's where the majority of the fraud is from, not on the enrollee side, pretending to have low income or be eligible for a program that they're, for Medicaid when they're not actually eligible.
And do you have a sense of who is most at risk of losing Medicaid as a result of these cuts, or will it just depend on kind of what avenues they go through, what changes they actually make to the program?
I it depends on what Congress decides to pass, but the current conversation right now is mostly focused on Medicaid expansion, though that could change.
Mhm.
And
And I
again,
do,
those are
yeah.
people 19 to 64 who have incomes below 138% of the federal poverty level generally.
And there are laws in place in a number of states where if Congress changes the percentage that they pay for those expanded Medicaid, then they will eliminate the Medicaid expansion automatically. So that's a big concern. I think in 12 states may have laws like that that will eliminate Medicaid expansion. And as Robin said, we need to be expanding it so that more people have it, not eliminating it.
Mhm.
We are at the top of the hour, so I just want to say thank you very much, Heather and Robin, for your insightful presentations and for answering questions. And thank you so much to everybody who attended and the great questions you asked. Sorry we couldn't get to all of them. And thank you to the NCCS team who made this happen. We really appreciate it, and we will be sending out the slides and the recording. Thank you.
Thank you.
Thanks, everyone.